Thank you for joining me today. Today we're going to cover and make comparisons about corneal sclerals and sclerals. I'm sure we all agree that if you're fitting the irregular cornea, that scleral lenses or semi-scleral lenses are a part of the arsenal that you must have to solve some of these very difficult fits. But is there a difference between the corneal sclerals and sclerals? And should we consider using corneal sclerals or sclerals depending on the case that we are addressing? Let's get our definitions right. Corneal scleral lenses have shared bearing on the cornea and sclera, but most of the bearing is on the cornea. They have limited tear reserve because you get some tear exchange, whereas scleral lenses have all their bearing on the sclera. They completely vault the cornea and have almost unlimited tear exchange depending on the diameter of the scleral lens. If we look at corneal scleral lenses, you can see here quite clearly, here's the limbus, that the landing zone is just inside the limbus. People have said to me, aren't you concerned with that? Initially, perhaps I was a little bit, but it has not been any problem at all. And many thousands of fits of my XL design has not caused any problems to those limbal stem cells. So you can see the bearing zone here inside the limbus. And you can see it here again. This is a scleral lens, so we do get some conjunctiva trapped underneath the lens. Here's the limbus here. So the landing zone is on the conjunctiva, completely outside the limbus. So why the dramatic increase in the use of scleral lenses over the last 5 years? And we should look at the factors which have driven this change. Particularly, I probably should extend that to 10 years now, but particularly over the last 5 years, there's been a huge uptake of fitting scleral lenses. Obviously, the comfort and the stability are the two major driving factors. Now, they're just about as comfortable as soft lenses initially. They give a very stable result and give good, stable vision. I think they're easy to fit, probably easier to fit than some corneal lens designs. And for some environments, such as dusty environments, they have a big advantage. They're also ideal for some dry eye and some corneal diseases where you actually want to trap tears behind the lens and bathe the cornea in the tear layer. And don't forget, financial results for the laboratories are much better return for the laboratories. It doesn't take them much longer and much more effort to make a scleral lens compared with the corneal lens. So do remember that as far as the labs are concerned, they have a big incentive to want to drive the use of these larger lenses. But is there any possible downside? Before we go into that, I just want to talk about the past. You know, we've successfully rested GP lenses or corneal lenses on the cornea for many years. You go to a scleral lens conference or talking about scleral lens, and you find immediately the lecturer will start saying, you mustn't touch the cornea. And that is very true if you've got no movement. If you don't have movement, you don't have tear exchange, you do not want the lens to rest on the cornea. But if you do have tear exchange and movement, it's not a problem at all. We've done it with corneal lenses ever since we had contact lenses back in the 1940s. So here's my philosophy. You have 20 to 30 microns of clearance over the limbus. That can actually look like touch because you need at least 30 microns to get fluorescence. The landing zone is just inside the limbus. You can see it here. It's less than a millimeter wide. If this landing zone is too wide, the lens won't move enough. You have 30 to 50 microns clearance here, minimum of 30, maximum of 50 over the highest point on the cornea. In keratoconus, that's central, but in pellucid, it's right down here. And then you have a nice fluorescent layer out to the edge of the lens, and that's going to be at least 50 microns deep, and probably in many cases a little bit more. So are there any scleral lens complications? Here was a poster that was put up at the GSLS conference in 2017. And they had looked at, I think, over 1,000 cases and summarized what the problems were. So over a quarter of the patients reported midday fogging, nearly a quarter had limbal hyperemia, and a significant number had corneal staining. Also, Pat Caroline reports that between 25 to 30% of scleral lens wearers have conjunctival prolapse. So not without their complications. What factors should we consider when we do a comparison between corneal sclerals and scleral lenses? And I've listed the ones that I want to consider today: oxygen availability, the lens settling time, tear exchange, lens diameter, and midday fogging, corneal changes such as epithelial bogging, conjunctival changes such as corneal prolapse, comfort, and handling and removal. And we're going to spend a little bit of time going through each one of these factors. So let's start with oxygen availability to the cornea. This is a paper that was put out several years ago when the scleral lenses started to become quite fashionable and used quite a lot. And the researchers found that only in the best case scenario for current scleral gas permeable lenses, considering lens thickness, material decay, and tear layer thickness values beneath the lenses, would they allow for sufficient tear layer oxygen tension to preclude corneal hypoxia. And what they were saying at that stage, use the highest decay materials and try to keep your corneal tear layer thickness to a minimum to minimize hypoxia of the cornea. This is an actual picture I took of a girl that was traveling in New Zealand. She had been fitted elsewhere in the world. She was traveling here, had only worn the scleral lens for 9 months, and this is what had happened to her graft. Worst case scenario, this is exactly what we never want, but you have to be aware. I believe scleral lenses on grafts do pose a risk, particularly old grafts, and I'll talk a little bit more about that as we go through today. What factors influence the oxygen availability of the cornea that we should consider? The thickness of the lens, the average thickness of the lens over the cornea, material decay, tear layer thickness, and whether the lens moves or not. So typically scleral lenses do not move, so we can take out this last factor here. We don't get a lot of tear exchange. Corneal scleral lenses have some movement, and we know they have significant tear exchange when fitted correctly. This was a hypothetical look at trying to predict the amount of oxygen available through a scleral lens to the cornea. Researchers did this several years ago, and here we have the lens center thickness in microns. Here we have the center tear layer thickness, and most laboratories say you need at least a 200 tear layer thickness here. So the amount of oxygen available to the cornea in fat units is listed for each one of these lens thicknesses. When we look at the Holden-Mertz criteria and the Harvard-Bonanno criteria, none of these two criteria are met for daily wear under a scleral lens. If we look at the corneal scleral Rose K2 XL, where you have a center thickness of only 140 microns, I postulate I've used here a tear layer of 35 microns, and you have a high decay material, you actually get a decay available to the cornea of nearly 3 times what we require. Even if we use a material of 100 decay, we still have double, at least twice what we require to meet the daily wear requirements for the cornea. So another thing you may consider is when we make these types of calculations, we always talk about the center thickness of the lens. But really, is that appropriate? Because the lens thickness over the cornea, particularly with grafts over the graft junction, is just as important. So with my design, I've tried to keep the lens thickness as minimal as I can over the whole area of the lens. It does make the lens a little bit more subject to warping. I'm not going to talk about getting around that today, but there are ways of getting around that the laboratory can help you with. So the more parallel these two surfaces, the thinner we can keep the lens, the higher the decay is. In Rose K2XL, the average thickness over the lens is around about 0.2 millimeter. However, you say, well, you talk about not getting enough oxygen to the cornea, and yet several studies have shown that the amount of corneal edema we get is in the range of the physiological edema that occurs during sleep of 4%, and is around 2%. Excuse me. So why do we get these differences between the hypothetical model, where we should be seeing edema under scleral lenses, and the studies which have said that we're not really seeing it? What are the factors considered? Most studies are done on normal healthy corneas and are neophyte subjects, so people who haven't worn contact lenses before. Most studies are only up to 8 hours of wear, and patients we know will wear them much longer than these, often up to 16 hours a day. With the 3 to 4% normal corneal swelling which occurs overnight, if we place the lenses on the cornea immediately on first awakening, does the cornea ever get a chance to recover to baseline, or do we just add to the 3 to 4%? After daily wear, does the cornea have time to recover to baseline before retiring? So if we get this 2% or 3% swelling during the day, we go to sleep, is this cumulative, and does it get worse over a period of time? Do fitters take into account the endothelial count, because it's very, very important? Obviously, the less the endothelial count, the more likely you are to have problems with the corneal edema. And this means that the age of the graft needs to be taken into account. Our old grafts have a much lower endothelial count than new grafts. Do the fitters monitor the corneal thickness over time to check for edema? I suspect in the most cases they don't. So what about lens settling time? The second fact that we want to consider. If you land the lens on the cornea, as we showed you here with a corneal scleral lens, you don't get a lot of compression. And there are several studies to show how much compression you get with a scleral lens. But let's make a comparison here. So this was a study done with a 15 millimeter scleral lens at the Mayo Clinic, and they showed that these lines represent each individual case that they looked at. This was where the lens sat with the tear layer clearance here within 5 minutes of placement, and this is what happened 2 hours later. So what were their conclusions in the study? That with a 15 millimeter scleral lens, approximately 50% of the initial clearance was reduced after 2 hours. So the lens settled, so the tear layer thickness was in fact about half after 2 hours. However, adequate time must be allowed for the lens to settle before making an accurate assessment of the tear layer, and excessive settling of the lens could reduce the fluid volume and increase the contact with the cornea, which you obviously want to avoid. And their final conclusion was the optimum time for adequate lens setting has yet to be determined. So that's after 2 hours. And here is the study here showing what happened after 2 hours. And you can see that the actual amount of clearance varied from 19 microns. So in this case, there was very little change in the tear layer thickness. But in one case here, there was a huge change of over 200 microns. This study here talks about after 6 hours of clearance as to what happens. And you can see in this study, after 6 to 8 hours, the actual change in clearance varied from 100 to 390 microns. But that's nearly 400 microns of change after 6 to 8 hours of wear. So something where you think you've fitted a scleral lens accurately, it can settle back hugely over a period of a few hours. What about a corneal scleral lens like XL? Because you've got the bearing zone on the cornea and not the sclera, usually it settles to its final position within about 20 minutes of first insertion. And it usually doesn't change by more than 20 or 30 microns. Scleral lenses, as those studies show, take several hours, and the degree of compression is very unpredictable because the conjunctiva can compress over 150 microns. So very difficult to actually work out where the lens is going to settle to. This was sent to me from an Italian practitioner who had fitted XL and wanted to know about the settling. So you can see here at the time, just take that back there. So when the lens was first inserted, he had 85 microns of clearance. 30 minutes later, he measured it again and he had 84 microns of clearance over the highest point on the cornea. And after 8 hours, he still had 85 microns. So basically, there had been very little change after the initial insertion with the lens. And that's not atypical to see with XL. What about lens movement and tear exchange? So we don't normally talk about tear exchange or lens movement with semi-sclerals, but with XL we do. And when it's fitted correctly, I like to see about a 0.5 millimeter, 1 millimeter on blinking, as you see here, when the lens first goes in. As the lens settles, that becomes just discernible. So you just see movement, but you should still see tear exchange quite easily. So if we have excessive amount of lens clearance, as we do here, replay that video, that will be uncomfortable for the patient. And sometimes you will get bubbles coming in at the edge of the lens. And here we have a scleral lens, and you can see basically there is no movement that you can see there at all. However, is tear exchange important? And I'm going to talk about a couple of studies here where they looked at the tear dynamics under the lens. So in this particular study, they wanted to evaluate the post-lens tear dynamics, the amount of tear exchange at 20 minutes and at 5 hours in 20 neophyte wearers. So people had never worn lenses before. So the method they used, all subjects wore the lens bilaterally for 5 hours on 3 separate occasions. And then tear exchange was measured by putting a small amount of fluorescein on the conjunctiva, a few blinks, and then watching to see how quickly that fluorescein entered underneath the lens during lens wear. So they used a stopwatch to observe the first signs of fluorescein in the post-lens tear reserve as after the lens was put in. What was their conclusion? Some tear flow in the reserve under the scleral lens was observed at 20 minutes and in some patients after 5 hours. However, after 5 hours where roughly 1/3 of the subjects had absolutely no tear flow into the post-lens reserve. And the longer the lens was on the eye, the more it settled, the less likely were to get tear exchange. So you can see here, this is an XL corneal scleral lens, very easy to illustrate tear exchange. You simply put fluorescein in the eye, get the patient to blink a couple of times, bring the lower lid up, and you should see very easily the fluorescein enter underneath the edge of the lens, as you can see here. And that can be observed inferiorly or superiorly. So without tear exchange, reduced oxygen levels, trapped metabolites and discarded epithelial cells must occur. So pH and osmolarity changes under lens must also occur if you're not getting tear exchange, which poses a higher risk of long-term metabolic and physiological complications such as microcysts, infections, and corneal vascularization. So for me, it's great to have tear exchange if you possibly can. So once again, people say, how important is it we don't get much tear exchange with a scleral lens? So this was a study that was designed to assess and compare the effect of a corneal scleral and scleral lenses on some tear film parameters and also the central corneal thickness in healthy presbyopic subjects. Their methodology, they had 30 subjects wear either a corneal scleral or scleral lens randomly assigned of neutral power. Material had a decay of 100, They looked at the tear meniscus area, the size of the tear meniscus. They looked at the central corneal thickness, and they looked at the osmolarity of the tear layer at baseline, at 20 minutes, and 8 hours after insertion. So what were their results? The tear meniscus area shows statistical differences at 20 minutes and after 8 hours, with the corneal scleral lens leading to a smaller reduction of the tear meniscus and lower hypoxia stress than the scleral lens. So both the corneal scleral lens and scleral lens showed changes, with the scleral lens showing more change than the corneal lens. Also, the central corneal thickness shows statistical difference at 20 minutes and 8 hours, again being lower for the corneal scleral design. Also, osmolarity changes were different, but again being lower for the corneal scleral design. So this study shows that if you put a contact lens on the eye, whether it's a corneal scleral or a scleral lens, you will get changes in these factors. What about the lens diameter? If you land a lens totally on the conjunctiva, the bearing zone or the landing area, and therefore the diameter of the lens needs to be bigger. And the answer is why. So here we see a poor fitting scleral lens. It's indenting, hiding into the conjunctiva. This will seal off. You're not going to get tear exchange here at all. What we're trying to achieve with the scleral lens is a nice parallel fitting over the conjunctiva here. So the landing foot needs to be relatively large. And I compare this with trying to walk through snow with just your shoes on, and you'll sink in. If you increase the bearing area, you won't sink in like you do here. Exactly the same applies to a scleral lens. The wider the bearing area, the less likely the lens is to sink into the conjunctiva and seal off. So lenses that land entirely on the conjunctiva need to be larger to prevent the lens sinking into the conjunctiva and a consequent binding. And typically, because of that, scleral lenses need to be bigger than corneal scleras and are often 16 millimeters and bigger. But so why go bigger than you need to? Small diameters have better alignment with the sclera. We know that the eye is more rotationally spherical. There's been several studies say up to about 15 millimeters, and we have less toricity. The bigger you go, the more you have to consider the toricity of the eye. Therefore, the need for toric periphery or asymmetric options is reduced if you can keep the lens under 15 millimeters. Also, it makes it easier to handle, makes it insertion removal. The bigger the lens, the more difficult. In a study that I did on Excel with about 150 cases, about 10% had significant problems on insertion and removal, and about 5% completely gave up on Excel because they just couldn't handle them. So it is a factor you have to consider. Smaller diameters are less fear-provoking than sclerals, and XL is much more similar to a soft lens, and most people can insert a soft lens without too much difficulty. So Rose K2 XL, the standard diameter is 14.6, but you have a range of diameters, and what you're aiming to try to achieve with this diameter is a lap outside the limbus of between 1.3 to 1.5 millimeters. What about midday fogging? Midday fogging was something we used to have to worry about with corneal lenses, but as soon as we got into scleral lenses, Pat Cronline, his studies show that around 1/3 of patients experience midday fogging after 2 to 4 hours of wear. Very inconvenient because it cuts your vision down. The patient needs to take the lenses out, refresh the solution in the lens, and put it back in. They're not particularly convenient. What causes it? Work performed by Dr. Maria Walker at Pacific University found the protein content in the TLA was unchanged, but the lipid content increased. So it was the goblet cells in the conjunctiva that were probably responsible for this midday fogging. And it was worse, the higher, the deeper this tear layer, the worse the amount of midday fogging was. Very infrequent with corneal scleral lenses. Why? Because we have a very minimum tear layer thickness of around 50 microns, And the conjunctiva with the goblet cells is not trapped underneath the lens. So here's XL, and you can see here we don't trap the conjunctiva underneath the lens here, where it is with a scleral lens, you do trap it, and therefore the goblet cells excrete their fluid underneath the lens, which causes the midday fogging. You can see here with an OCT, this is an ideal fitting XL lens, and I'm aiming to get a minimum of 30 microns clearance over the highest point of the cornea. This is obviously a keratoconic because it's quite central, and a maximum of 50 microns. So that's what you're trying to aim to achieve. The shallower the tear layer, the less likelihood of midday fogging that will occur. What about conjunctival changes? We never used to hear about epithelial bogging with corneal lenses, but certainly it's an expression we see. And Pat Caroline predicts that it's because the tears are trapped underneath the lens. Whatever you put in the lens bowl is very, very important. So preservative-free saline is very important. You don't want to put preservatives in that bowl when you insert it, because those are likely to stay there most of the day and can cause the types of problems that you can see here, because we get so little or no tear exchange underneath the lens. No cases of epithelial bogging reported with the corneal scleral lens XL at all, and that makes sense because we are getting tear exchange. The solution is not quite as important because we are getting tear exchange underneath the lens. Here's another study trying to measure inflammatory responses in the tear layer underneath the lens. So to measure inflammatory mediators in the scleral lens reserve in healthy eyes, compare them to basal cells. So can we actually measure the inflammation in the tear layer? So 15 subjects wore scleral lenses for 4 days, and the inflammatory mediators, which were MMP 9 and 10, were quantified in the fluid reserve. So what were their results? That these mediators, or these inflammatory mediators, were elevated in the fluid reserve in scleral lens wearers after a certain amount of hours of wear. So we do know it happens, we can measure it. Is it going to be a long-term issue? Anyone knows, but it's something we should be aware of. Another study here looked at corneal surface wettability and lens wettability. In this study, the aim was to evaluate the anterior surface of the scleral lens wear and ocular surface after 1 month of scleral wear in patients with keratoconus. What were their conclusions? Scleral contact lens wear surface keeps its wettability after 1 month of wear, which is not surprising. However, the wettability of the ocular surface, or the cornea, is worse after scleral contact lens wear after a month. So that was another thing, that scleral lens wear does affect the wettability of the cornea. What about conjunctival changes and prolapse? In some scleral contact lens wear, the conjunctiva is sucked underneath the bowl of the lens, resulting in these waves, which eventually will actually attach themselves to the cornea and can have to be surgically removed if you want to try to get rid of them. They often actually vascularize over a period of time, which is absolutely not ideal, and it's rather unsightly. So Pat Caroline said up to 25 to 30% of patients get this happening and not occur with the corneal scleral lens. Why? Because we don't actually have the conjunctiva trapped underneath the lens. You can see here, here's the scleral lens, conjunctiva is trapped with XL. With the corneal scleral, the conjunctiva is not trapped underneath the lens, so you actually can't get this problem. So in my history with XL, it's now been around since 2015. We have had no cases reported to me of conjunctival prolapse. What about comfort? Because of movement and a high degree of edge lift, the initial comfort is a little bit more, so not quite as comfortable initially as a scleral lens. However, this very quickly settles down, and usually the comfort of a corneal scleral lens is as good as a scleral lens within a few minutes of insertion. And you can see here, this is an ideal fitting corneal scleral lens, a little bit of movement, not a lot. Excessive movement is uncomfortable. So if you put a lens in and the patient says, that is fantastic, I can't feel it, I can just about guarantee you it will have a tight edge. With my design, with XL, there should be some sensation of edge when it first goes into the eye. But although initial comfort is good with a tight edge, the long-term outlook of comfort and outcome is not as good, and for the health of the cornea is not as good. So there's a balance between initial comfort, which may not be quite as good with a corneal scleral lens versus a scleral lens, and long-term outcomes. Finally, handling and removement. Always you put the plunger or the sucker on the edge of the lens, never centrally, otherwise it makes it impossible to remove. And with the correct fitting, it should come out quite easily. With scleral lenses, the amount of force required to remove the lens is significantly greater than it is with a corneal scleral lens. You can see how easy this is to remove here. Is that an issue? With these, so scleral lenses we know actually suck back on the eye and have quite a lot of suction. Is that an issue? Well, there was a paper that was designed to address that here, and this was presented in Contact Lens Anterior Eye last year. And they looked at intraocular pressures and they measured the intraocular pressure of the eye without a lens on and with a lens on. They measured it superior to where the lens sits on the conjunctiva or on the sclera, and they measured it without the lens in and exactly the same place with the lens in. What were their results? 19% of patients showed an increase of greater than 10 millimeters. The average for all subjects was 5 millimeters, and one patient had an increase of 15 millimeters. So they suggested this is something that needs further investigation, and Pat Caroline did this and presented a paper this year at the GSLS Congress. We used 31 subjects. His average IOP increase was 6 millimeters. 9 eyes had increases of greater than 10 millimeters, and one subject had a massive increase of 18 millimeters of pressure. So it's something, if you're going to fit scleral lenses, you have to be aware of. You may be increasing the pressures. What are the mechanisms? We're not actually sure at this point, but it's something you should be aware of because it may certainly cause long-term issues, particularly if the patient is on glaucoma treatment or has narrow anterior angles and more at risk for increasing pressures. So there are some disadvantages of corneal scleral lenses. I think the initial comfort's not quite as good, but that's not a problem long-term. I think they're a little bit more difficult to fit because you do get some edge sensation. You have to fit them more accurately onto the conjunctiva. If you don't, you get problems such as discomfort and bubbles come underneath the edge of the lens. So I think with a scleral lens, which vaults over and you get, because the conjunctiva it sinks down, it's a bit easier to fit a scleral lens. Not as suitable for extreme dry eye because you want to trap the tears behind the lens. Not as suitable for any condition where you have scars on the cornea, such as radial keratometry, keratotomy, where you don't want to actually allow the lens to rest on the cornea. Not as suitable for corneas with extremely high sag, such as globus. And I think some corneal diseases where you don't want to actually touch the cornea, they're not quite as suitable as scleral lenses. However, they have a lot of advantages, and I'm just going to summarize these before I finish up. Much less binding than scleral lenses if they're fitted correctly. Conjunctival compression is much less than sclerals, no doubt about that. Therefore, there is less risk of increasing the intraocular pressure. So that's important for any patient at risk. Significantly more tear exchange, which can be easily illustrated than sclerals. Some movement to refresh the tear layer under the lens, and therefore they pose less risk for corneal grafts. Corneal grafts, particularly old grafts with low endothelial count, are really at risk with scleral lenses. You've got to be very, very careful and monitor them very, very closely. Also, at examinations, when a patient comes back and you want to check the cornea, with a scleral lens, you actually have to remove the lens to actually be able to stain the cornea. With a corneal scleral lens, you simply put the fluorescent on the conjunctiva, a couple of blinks, a little bit of manipulation, and you should see fluorescent enter underneath the lens. So you don't need to take the lens out, which is a big advantage. Because they are smaller, a reduced need for toric options. Usually settle within 20 minutes, so you don't need to think about where that lens is going to end up. It's not a 4-hour job. Usually within 20 minutes, you know where the lens is going to actually end up. No conjunctival prolapse or corneal bogging ever reported with XL. But midday fogging, it's very uncommon. I have had a few cases, but very, very uncommon. So that means much less frequently you have to remove the lens and have it refilled during lens wear. Don't need to be as large as Squirrels, and much easier, I think, to remove. The suction forces are much less. So you might say, well, fine, I'm using scleral lenses. Corneal sclerals is a bit of a new learning curve for me. When should I use them? You know, when would you see a big advantage of a corneal scleral lens over a scleral lens? I think any case where you have lower endothelial counts, such as keratoconus, grafts, post rings, pellucid, and corneal injury, you should immediately think of a corneal scleral in preference to a scleral lens. Also, obviously, where you have smaller eyes, where insertion and removals are an issue, patients at risk with a raised eye, intraocular pressures, I would always use a corneal scleral. And where fitting time is an issue, do hospital clinics have enough time, for example, to send patients out and try to get them back 4 hours later to assess where that lens has eventually ended up with the tear layer. So here's a good fitting XL lens on a keratoconus patient. The lens moves nicely. And this was a study done on 712 keratoconic patients to look at the endothelial count. What they found is the more severe the keratoconus stage, the lower the endothelial count. So in keratoconus patients with rigid contact lenses compared to eyes without contact lens, they found a statistically significant higher coefficient of variation of the endothelial size as well. So in summary, what does that mean? It means as keratoconus advances, your endothelial count gets less, and also your polymorphism, the size of the variation of those cells, gets greater. And we know with corneal lenses that these changes take place over years, and eventually you get cornea exhaustion and the patient can't wear lenses. So endothelial is a really important factor to consider when you're considering whether you should have a scleral or a corneal scleral lens. This is why with keratoconus, which we know have lower endothelial counts, I prefer to have a corneal scleral lens. Here's another study on endothelial counts, looking at 5-year endothelial counts post penetrating keratoplasty. So what happens in grafts to endothelium? At baseline, 10 days, the mean, that was 10 days post-surgery, the mean endothelial cell density was relatively normal and had a range of between 2,300 and 2,500 here. However, at 5 years, the endothelial count had dropped from here to here, which is a huge drop. In fact, 56%. So just by being a penetrating graft, we have immediately made the cornea exposed to losing endothelial cells very quickly over those first 5 years. What about if we extend it out longer? We know that in this study here, another study looking at 15-year after penetrating keratoplasty, the annual rate of endothelial cell loss between 3 to 5 years, that doesn't sound a lot, but you multiply that by 5 and you can end up with close to 40% loss in the first 5 years. And this continues over a period of time. So older grafts are very, very much at risk for endothelial problems and edema of the cornea. Just be aware of that. I would never use a scleral lens on an old graft. So is it safe to reduce oxygen levels further to these already compromised corneas with lower endothelial counts? And pellucid is an ideal, absolutely ideal condition for a corneal scleral lens. You get this beautiful pattern that you see here, when the patient blinks, you get a nice circulation of tears behind the lens here. And also, in some cases, you have to use what we call ACT, or tuck the bottom of the lens in, which is another option you have with Excel. So why do I generally prefer corneal scleral lenses over scleral lenses? They can be used in the majority of cases where a scleral lens is indicated, give the same advantages of comfort and stability that sclerals provide, without many of the long-term potential downsides that sealing off the cornea can cause. And there was a very interesting statement in a recent in F. Van Werp's letter that he puts out, the eyesight letter each month, came out in June, and his comments were, managing scleral lens wear is probably harder and more challenging than fitting scleral lenses is. I think that was a major statement. So if you do fit lenses, scleral lenses, it's something we do need to watch long term, and particularly grafts, particularly older grafts, which are highly at risk. I thank you very much for joining me today. I do hope I have made you think about corneal scleral lenses versus scleral lenses, and think when you might want to use a corneal scleral lens in preference to a scleral lens. Thank you very much, and enjoy the rest of your day.